Good morning, everyone, and welcome to this session. Cyclones, extreme weather events, flooding, temperature shift impacting vector range, humanitarian situations, accelerated urbanization, environmental changes. All these are potential events expected to be actually accelerated by climate change in the coming decades. This session is all about assessing what impact could climate change have on tropical health. And to do this morning, we have a panel of speakers, but I would like, before providing more details, just to say that unfortunately, we have some speakers who won't be able to join us this morning. We have Fortunate from Zimbabwe. Unfortunately, he couldn't get the visa, so he won't be able to attend. We also have our keynote speaker, Madeleine Thompson from Wellcome Cross, the head of adaptation department there. She won't also be able to join because of a late health emergency in her family. So we think about her, but unfortunately, it means that she won't be able to attend the session this morning, and she can't even do it online. It means what? We have a bit more time this morning in our session. So what we will do to try to mitigate this situation is to allow more time to our speakers. So you'll be glad, speakers, to know that you don't have to rush. You have a bit more time. And also, we will be allowing more time for questions. And those questions will come from us in the room, but also online. I'm glad this morning to collaborate with my good friend Dave. Dave is there. You'll be scanning the online platform to look at potential questions. Therefore, we encourage our colleagues online to really feel free to make comments, to provide your questions in the chat box. And Dave will collect them and we stand ready to share those questions and comments with us in the room. So, and the second way we want to mitigate is that after each speaker has completed his session, we hope at the end to call the three of them forward for a panel discussion. And the panel discussion will focus on the topic that they covered, but also we allow the audience to raise any issue related to climate change that may not have been covered, but which is still important. So I encourage you to really write down any comments, any questions that you have. We want to turn this session into a dynamic, interactive session, and we'll do that all together. Having said that, let's start with our first speaker. Is Jennifer Lord from the Vector Biology Department. She is a MRC Career Development Award Fellow, and she'll be talking about the impact of climate and ecological breakdown. How should we respond? Jennifer, over to you.
I was actually looking forward to rushing and getting it over with, but I'll try and take my time because I have a tendency to go at 100 miles an hour. I'm Jen. I'm an ecologist here at LSTM. I've been here for about 10 years, and working mainly on vector-borne disease. But I only really want to touch on vector-borne disease this morning. What I actually want to talk about is responsibility. And I'm really sorry, but I'm going to start with part of a poem. Is it well that while we range with science, glorying in the time, city children soak and blacken sense and soul in city slime? There, among the glooming alleys, progress halts on palsied feet. Crime and hunger cast our maidens by the thousand onto the street. This part of a Tennyson poem was used by Alfred Russel Wallace in his book, A Wonderful Century, which was actually published in the same year that LSTM was founded. He used the poem, quotes from others, along with empirical evidence to call out social inequality and to demand a systemic change to society. On reflecting on the 19th century, he stated that as one symptom has been gotten rid of, a new disease has emerged, or an old one reappeared elsewhere with increased virulence. This is a narrative not just for the 19th century, but for the entirety of human civilization. Over thousands of years, the emergence and spread or change in epidemiology of human infectious diseases has been caused largely by how humans have modified their ecology and environment. As one example of this, Rose and colleagues defined 3 epochs which determine the origin and spread of the human specialist mosquito Aedes aegypti, which is a vector of dengue, yellow fever and other viruses. The 3 epochs were water storage at the end of the African humid period, the transatlantic slave trade and urbanisation. I would add a 4th epoch to the 3rd. I don't know if you can have overlapping epochs, perhaps not, but the climate crisis. So scientists predict that there's already been around an 18% increase in dengue risk in Asia and the Americas due to climate change. And estimates suggest that there'll be an additional 40 to 57% increase in these regions by mid-century due to the climate crisis. Worst case scenarios predict 1 billion people will be exposed to new Aedes-borne virus infections globally. We are in uncharted territory. We are already seeing more frequent intense wildfires, floods, droughts, heat waves, crop failures. Changes in infectious disease is just one of many symptoms of the climate crisis. By the end of the century, some scientists have predicted between 1 and 3 billion people may find themselves in unlivable areas. The way that I've been trained is to focus on a disease or set of diseases and their control without really focusing much on the root causes, the modifications that cause them in the first place. Whilst this presents an organising frame within which to work, it comes with the assumption that the underlying modification or root cause is outside of my organising frame, as though it's not my responsibility and it's being dealt with by someone else. Going back to the 3 epochs, it's really clear just from this example that not all modifications are equal. When the underlying modification is a human justice issue, I've been asking myself, what is my responsibility beyond the disease itself? In a recent LSTM book club organised by Lucy and Samir, we read King Leopold's Ghost, about the atrocities of King Leopold and others in the Congo in the late 1800s and early 1900s. And one day I was sat with King Leopold's Ghost in my office, and my attention was drawn to a set of old Tsetse and sleeping sickness books that were handed to me by Professor Steve Torr to be custodian of. I absent-mindedly took one of these books off the shelf. It was translated by Nabarro in 1907. Sleeping sickness is endemic in the Congo Free State. The mortality, which was in 1896 13%, rose in the following years to 39%, and in the first quarter of 1900 to 73%. The majority of children died of the disease. Todd shows that before Europeans entered the Congo Basin, the disease seems to have been confined to the lower region of the Congo and to the banks of the main river. With the advent of white men, new steamer and caravan routes were opened up, with the result that the infected areas have increased in number and extent. It's clear from this example that disease wasn't a symptom or a side effect of progress on the people it affected. It was just another form of violence inflicted on those people. And I've been wondering about the fact that there's 3 scientists that passed on these books, 3 generations of scientists between me and the atrocities and King Leopold, and whether in 3 scientists' time, if someone finds remnants of my career, like notes in an old book or a manuscript online, will they see that I was able to do something different, maybe something, maybe see I was able to do something more, or maybe do something entirely different. So some global health researchers have been warning against tunnel vision for climate and health by focusing on the symptoms rather than the root causes. The climate crisis is just one of many symptoms of a current way of being, particularly by a global minority, which is destroying life, human life, and other than human life on our planet. There are 9 processes which maintain the stability and resilience of life on Earth, and 9 boundaries beyond which these processes break down. 6 have been crossed, and CO2 is just one. With respect to CO2, 92% of excess emissions over the last 150 years have been from the global north. Colonialism has facilitated overconsumption by the wealthy through the development of our current global economic system, which was founded on war and violence. It's estimated that because of this system, on average, there's a drain from the global south to the global north of around $10 trillion a year. This historical legacy and unequal exchange is a major driver of social inequality, and it's also a major driver of the climate and ecological crisis. A very recent Lancet commission, A Just World on a Safe Planet, provided quantitative evidence for the impossibility to meet basic needs for all, while trying to stay within a safe and just corridor for climate, whilst current levels of social inequality exist. At the same time, authors of the Lancet Countdown on Climate and Health state that while the climate crisis is the greatest threat to global health in the 21st century, it's also the greatest opportunity to redefine the social and environmental determinants of health. In the Lancet Commission, A Just World on a Safe Planet, the authors provide an analysis which shows that in order to try and stay within a safe and just corridor for climate, there has to be fundamental changes to production and consumption patterns. This will require not only sustainable technologies, but also a redistribution of resources. It requires social justice. Global health researchers should play an important role in this. During this symposium, impactful research on climate and health, resilient health systems, and also disease control is being presented. Can we create space to also contribute to the fundamental changes needed in our society? Global health researchers should play an important role in this, but privileged and economically wealthy populations are often left out of the organising frame in global health altogether. In 2019, Stephanie Nixon published the Cohen Model of Privilege and Critical Allyship in Public Health. On the top of the coin are those with privilege, and on the bottom of the coin, those who are oppressed, and the coin represents a system or systems of inequality. In this paper, she writes, disappearing the top of the coin, and often the coin itself, functions to maintain the status quo, because what one frames as a problem sets the universe of conceivable actions to address it. The bottom of the coin is commonly framed as the entire story of health equity as opposed to just one part. If the problem was viewed not only as the bottom of the coin, but also the coin itself, then a different set of solutions could follow, such as changes to policy and law to create safeguards against discrimination produced by the system of inequality. And I've been asking myself recently, as I mentioned at the start of this talk, about the limitations of having a disease or set of diseases as an organising frame, and what I can do to contribute more to addressing global justice. And I've only got a few minutes here, and I'm not actually going to answer the question that I asked as part of this talk, but I can give a few pointers. So there's a recent publication, a guide for public health professionals on climate change litigation, and there was a workshop held recently at Imperial College London that brought together scientists and lawyers to discuss how population health data from LMICs could be used for promoting climate policy and in lawsuits. Just briefly, on an individual level, there's been a surge in publications on how giving tangible actions, how scientists, both in their professional and personal lives, can take action. We could and should be leading by example. Eck, Messling and Hayhoe, climate scientists, state, we contend there is no clear boundary between activism and science, and that it is pointless to try and separate the citizen from the scientist. Just like Tennyson and Wallace, in many ways, the way that I see the world is just a product of the time of my existence. And acknowledging that I'm on the top of many coins, I come with a lot of privilege. I see my role is to listen and then to try and have the lens through which I view the world changed and figure out with others how to respond. And as I mentioned, I never want to start a talk really with a question. I want to be able to give an answer. But all I hope for from this talk is to try and start a conversation at LSTM here and beyond about how to respond. Far away, beyond her myriad coming changes, Earth will be something other than the wildest modern guess of you and me. Earth may reach her earthly worst, or if she gain her earthly best, would she find her human offspring, this ideal person, at rest? Forward then, but still remember how the course of time will swerve, crook and turn upon itself in many a backward streaming curve. Thank you.
Thank you. Thank you so much, Jenny, for this talk. And we now have time for a few questions, and either online or in the room. We already have one here, and then over there as well.
Thank you very much for your important lectures or presentation. Just only it comes to my mind sometimes that why we are not correlating such factors like the improvement of the diagnosis, improvement in the knowledge, and in the process of increasing the burden of the disease. That means, for example, healthcare professionals, when they are, improve their knowledge and their capacity to work in certain types of disease, they will be reporting more cases. How we can correlate that with the climate change?
So, sorry, to summarise, how to correlate increased disease burden with the climate crisis?
Yes, accessibility to the healthcare facilities, improving in knowledge, improving in diagnosis, with the climate change.
How do you link the health situation with the climate change?
So I think there's researchers are already doing putting a lot of effort into that, particularly around Lancet Countdown on Climate and Health, who are estimating the burden of trying to attribute disease burden with the climate crisis. Oh, sorry.
Yes, okay, thank you. David?
Thank you very much, Jennifer. Nice to see you again. So many years. Just a point, and you touched on King Leopold's Ghost, which I think should be the set book. What you didn't say, and I know Steve gave you those old references, I have a slide or two on Alfred Lewis Jones. What few people don't know is the founder of the school was the sole contractor to provide the ships that took the troops from Belgium to the Congo and brought back rubber and ivory. And so it was Morel, who was his clerk, who blew the lid on the genocidal activities of the Belgians in the Congo. But the school had an expedition on sleeping sickness, as you know, and I actually got a slide of Everett Dutton, who died in the Congo in his coffin in Kasongo in 1905. So the school was heavily involved with what wasn't at the time known as genocidal activity. But I think we should recognise, as you rightly say, times have changed. And there is a picture somewhere of 4 people from the school going to receive a medal from King Leopold at Brussels railway station in the early days of the Eurostar. So I think that we should acknowledge that we were involved with people who were less palatable than perhaps we would like. But I've got the documents, and actually the school was also involved in bringing 4 Congolese patients with sleeping sickness.
I've got the book.
They died in the Royal Southern Hospital just past the cathedral, and post-mortems were done and published in the memoirs of the school.
Thank you, David. Acknowledging the past to build the future. That's what we need to do.
Can I just, just in response to that,
Yeah.
also just wanted to say, I mean, one of the reason I wanted to use that example was to also, I guess one of the things I've been trying to think of is what seems to be normal to me now, but in 3 scientists' time is going to feel like a horrific thing to do. So air travel is one thing, and you might know, probably most of you haven't seen this, but Surekha, I don't know if she's in the room, she's got the sustainability stand right at the bottom of the back room, and there is an air travel thing there. Please go and have a look. And I'm not telling you not to fly, I'm just saying let's have a conversation around the things that need to be changed.
Thank you. We have a question online, Dave.
We have an online question from Dr. Bipin Chandra. What are the most critical research gaps in understanding climate change's health impacts, and how are health data being collected and analysed to try and track climate change effects?
If anyone else wants, I mean, there's also probably people in the room that are better suited to answer some of these questions, because I'm way out of my comfort zone.
We'll come back to that question during the panel discussion.
Yeah, that would be great. Thank you.
Exactly. Thank you. Thank you, Jenny. We move to the next speaker. Thank you very much. Our next speaker is Eri Lucas, a lecturer in vector biology from the Department of Vector Biology. You'll be talking to us about implications of anthropogenic change on malaria vector population and transmission. Over to you, Eric.
Thank you very much, and thank you, Jen. That was an awesome talk, and mine will be considerably less inspiring. I don't really need to tell the people in this room that malaria causes over 600,000 deaths a year globally, 95% of which occur in sub-Saharan Africa. And the topic of this talk is how is this likely to change, and how might vector control need to change as a result. So a quick background on how you go about predicting the future of malaria. There's two main approaches. The first is based on theoretical malaria transmission models. So you start off with some giant equation that relates the stability of malaria transmission to a whole host of parameters, both from the vector and the pathogen. For example, how long the vector will live, how often it bites, how long the pathogen takes to develop, and things like this. And you make all of these parameters a function of temperature, and then you take some empirical data on how these parameters actually change with temperature. Here, it sometimes inevitably become a bit of a victim of extrapolation when your data don't quite cover the range of temperatures that you're interested in. And then you put all of this back into your model, and you end up with some prediction of how malaria stability changes with temperature. As a validation, you can apply these to current climate data to check how accurately you've predicted malaria prevalence. And then you use climate models, predicted changes in temperature in the future. You apply your model, and you end up with some future distribution maps for malaria. So that's the main approach that's based on these transmission models. And the other approach is based on current maps of malaria prevalence. So essentially what you do is you start with malaria and climate data, and essentially you overlay these two data sets, and you basically ask, where do we find malaria? What climate tends to happen in those areas where you find malaria? You use this to build a model that relates malaria to climate variables, and here you can chuck in whatever you want into this model. It doesn't only have to be climate. And you use this to predict the future distribution maps. So what's been the results of these predictions? Well, so far the results have been fairly consistent. So as a whole, malaria in Africa in the sort of by the end of the century is predicted to decline, basically because temperatures get too hot for primarily for the vector. And arboviruses such as dengue become a growing threat. And fundamentally, this is because the vectors of dengue, like Aedes aegypti, seem to have a higher tolerance for higher temperatures, and they're less dependent on natural water habitats that are potentially going to dry up. And instead, they can nest in human water containers, breed in human water containers, which inevitably will be found wherever you have humans. However, this is very region dependent, with some areas of higher elevation, such as parts of East Africa, or higher latitudes, such as South Africa, seeing increasing malaria cases by the end of the century. So here's an example of one of those predictions. So on the left, you've got current malaria distribution. And on the right, depending on what your climate model is, you might have much, much less malaria, or less, but not quite as much less malaria. But primarily in sort of West Africa, Central Africa, malaria decreases quite substantially. However, as you can see, in sort of the even with the more sort of pessimistic in terms of temperature, optimistic in terms of malaria model, you still get more malaria in this area here and down here. And Madagascar actually encapsulates this quite well. At the moment, malaria in Madagascar is primarily a sort of coastal lowland disease, and then by 2080 it's predicted to have just moved into the Central Highlands. So are we done? Like most of the models tend to agree that this is what's going to happen. So that's it, right? Next speaker. Well, obviously, if I thought that, I wouldn't be giving this talk. So as you can all imagine, and as you're all certainly telling yourself, malaria is incredible. Well, any disease is incredibly difficult to predict. Climate's difficult to predict. There's a huge swathe of factors that have not been taken into account. There's no time to cover them all here. I work on vector control. Specifically, I work on insecticide resistance, the genetics of insecticide resistance. And so 2 things that I want to talk about here are how might vector control itself be affected by changing temperatures and changing climate, and how might anthropogenic change affect the vector species composition. So let's have a look at the first of those first. So first of all, potentially changing practices. One reason that very, very, very often gets given for why people don't sleep under bed nets is because they're just too stifling under hot conditions. So if it gets hotter, is bed net use going to decline because more people are going to find it too hot to sleep under the bed nets? Things like this, are practices going to change as a result of increased temperature, increased aridity? Are people going to store more water? How are water practices going to change? How are these things going to affect vector control? And secondly, how will insecticide effectiveness change with temperature, or just generally control effectiveness change with temperature? So how insecticides change with temperature is very complex. It depends on the insecticide. It may even depend on species. So, permethrin, apparently. So this is work done quite a long time ago on a pyrethroid permethrin in, for example, Anopheles stevensii, in a resistant line and a susceptible line. In both cases, you get a U-shaped curve of mortality with temperature. So there's a sort of sweet spot between 20 and 30 degrees where permethrin achieves maximum mortality. In Anopheles gambiae, so admittedly for the resistant line, there's only 2 data points, so good luck detecting a U-shaped trajectory with 2 data points. But certainly in the susceptible line, there's no evidence of the U-shaped trajectory. If you look in Anopheles phonestus, this time with deltamethrin, so it's another pyrethroid, you again get this U-shaped trajectory of mortality with temperature. This is in a resistant line. In the same resistant line that's been selected to be even more resistant, mortality goes so low that you barely detect this U-shaped trajectory. On the other hand, in the same colonies, if you look at a different insecticide, bendiocarb, here you get a monotonic increase with temperature, at least within the ranges that were studied here. And so the question is, where are we on this curve? Because we know what the mean temperatures are. In any given area, you can very easily find out what the mean temperatures are. But at what temperatures does the vector encounter a bed net at night, indoors, when it's host seeking? It's probably not just the mean temperature of the area, right? So are we currently here, where as temperatures go up, efficacy of insecticides is going to decrease? Or are we here where the efficacy is going to increase? So we need to understand better for different insecticides, how are changing temperatures going to affect their efficacy? How will climate and temperature interact with different resistance mechanisms? And here, basically, the answer is we have absolutely no idea. So, as you all know, mosquitoes all over Africa are evolving to become resistant to insecticides, primarily pyrethroids, but also others. There's lots of different ways in which they do this physiologically. So, for example, target site resistance is where the protein that's actually attacked by the insecticide is mutated so that the insecticide is less effective at attacking it. But you also get metabolic resistance, where you have enzymes that actually break down the insecticide before they have a chance to achieve their maximum toxicity. And metabolic resistance is very often achieved by just upregulating the expression of the metabolic gene, so you just express more of that gene. We know that gene expression is affected by temperature. How is the expression of resistance genes affected by temperature? This we don't really know. That's something we need to look into. There's lots of ways of changing expression. If you want to increase expression of a gene, for example, this one here, there's, the regulatory apparatus of that gene is quite complex. If you want to increase expression of that gene, you can do it by messing with this bit, or this bit, or this bit, or this bit, or by straight up just increasing the number of copies of the whole thing. How are each of these different changes in expression, or each of these methods of changing expression, these different mutations that can change expression, how are each of those affected by temperature? Not the foggiest. This is a study we did recently. It's a genome-wide association study of resistance. We've used a couple of insecticides. These are the results for deltamethrin. This is 4 locations in Africa. We did a few more as well. There's a lot on this slide, but essentially every one of each one of these lines is the genome of Anopheles gambiae, and each of these little coloured points is evidence of association of that area of the genome with insecticide resistance. And the take-home message of this slide is basically that everywhere you look, both between and within populations, different genes seem to be associated with resistance. So there's a lot of different mechanisms of resistance out there. And even where you get consistent results, like, for example, CYP6AA1 is basically always associated with resistance to deltamethrin, it's never the same mutation twice. You look in one place, you look in another place, it will still be CYP6AA1, but it will be a different mutation. And even within a location, you will have more than one resistance mutations within the same gene spreading at the same time. How are each of these different genes, how are each of these different mutations affected by temperature? Again, not the foggiest. Okay, so that's how vector control itself might be affected. What about how might anthropogenic change affect vector species composition? And here, if you work on vector control, you know exactly what I'm going to say next, which is that we need to think about Anopheles stevensii. So if you don't work on vector control, Anopheles stevensii is a vector of malaria native to Asia and the Arabian Peninsula, which over the last few decades has been invading Africa via the Horn of Africa. The things you need to know about Anopheles stevensii is that it is urban. It breeds in artificial containers. We think it has a wider temperature tolerance than the native African vectors. In some places, in fact, it has adapted to hot desert conditions where it gets very, very hot and very, very dry. And it will spread malaria in those areas. And all of these properties are the same properties that Aedes aegypti has, that means that people are predicting that dengue is going to become a more serious problem in the future. Now, we can model the spread of stevensii in the same way as we model the spread of malaria itself. So this is a paper from 4 years ago. It uses data from the native range of Anopheles stevensii, and it predicts where the suitable habitats are in Africa. And at first glance, this might seem quite optimistic. It looks like Africa is a pretty inhospitable place for Anopheles stevensii once you get away from the Horn. But one of the parameters that went into this model is human population density. And each of these little blue circles represents a city of over 1 million inhabitants. And you can see that there's an awful lot more of those little blue circles in Anopheles stevensii's home range than there are in Africa. And in fact, population density turned out to be the second most important variable in this predictive model. So the first was temperature and the second was population density. So is it the case that the only reason that Africa is looking a bit inhospitable for Anopheles stevensii is just the fact that at the moment population density isn't quite high enough? So what happens if we build a model that just doesn't include population density? What if we just look at climatically, what's the suitable range for stevensii? So this is a paper published this year. This doesn't include population density. This is just climate variables. And here's the predictive home range, suitable range for Anopheles stevensii in the next 20 years and in the 20 years following that. And you can see that suddenly Africa looks much nicer place to be if you're an Anopheles stevensii mosquito. So if it is the case that population density is the only thing that's sort of limiting the spread of Anopheles stevensii into Africa, then obviously this is something that is going to change very rapidly over the next many decades. And it's something that we need to start including into our climate models. So to what extent is Anopheles stevensii going to be in all of these areas, and to what extent is the increasing human density going to make it a more suitable habitat? So if species composition of malaria vectors changes, then vector control methods will need to change as well. So Anopheles stevensii bites both indoors and outdoors. It rests both indoors and outdoors. And this reduces the efficacy of bed nets. So we're going to have to start rethinking the ways in which we control malaria. And I don't think, predicting these things is incredibly difficult. There's no doubt a lot of errors in what we've predicted. But essentially, I think preparing, like being ready to react. So, not reacting completely, but being ready to react and sort of knowing how we might need to react based on how things change, I think is important. So in conclusion, there's a lot of, many climate models predict that malaria will eventually decline overall, although even those models say that it's not always locally. So new populations that don't have any sort of experience of malaria are going to start experiencing it. But we need to be cautious. We don't know how the effectiveness of current interventions is going to change with temperature, and we don't know how the species composition is going to change. And I think we need to be ready to adapt as a result. And with that, thank you very much.
Thank you very much. Thank you very much, Eric. We have time for a few questions. While we are thinking. No. You can't go that quick. I have one for you. Oh, we have Liz. Yes.
Thank you. Sorry, just a couple of questions. So first of all, how adaptable do you think the insect is to changing climate conditions? I mean, they evolve pretty rapidly, don't they? So are we not going to see the endemic species just extending their heat tolerance? And the second thing is about the stevensii. So, obviously that would be like really bad news for big African cities like Harare, like Blantyre, like Lilongwe. And again, how quickly do you think that's happening? Do you think we've got good penetration already of the African subcontinent and that we're going to see malaria transmission anytime soon in the big cities?
The answer to both of those questions is I don't know. But first of all, on the question of adaptability, we don't know. So, yes, you're absolutely right that these species can and will evolve to some extent to the changing conditions. How rapidly they can do that, Anopheles mosquitoes are not everywhere. So they clearly do have limits. And if it was as simple as saying, if they can adapt, then they will, then they would have adapted to the whole of the globe, to both hotter temperatures and cooler temperatures. So there's clearly some limit to how quickly they can adapt and how strong the pressures need to be in order for them to do it. If the populations are able to simply shift to more suitable habitats, whether or not they will adapt sufficiently quickly to the changing temperatures, I can't say, and I think we need to understand that better. Anopheles stevensii, the penetration certainly is already very strong in the Horn of Africa. They've certainly established there, very much so, and we are already hearing reports of findings much further afield, as far as sort of Nigeria and Kenya. How long it is until they establish in big cities, again, very hard to say. And I think basically we need to start just looking into how do big cities in the native range deal with Anopheles stevensii, and can we already start sort of adopting similar practices in the big cities where it may well be spreading.
Thank you. We have a question online. Maybe we go to online first. Dave?
Yes, we have a few online questions. The first one is from Helen Allett, and she's asking, are there models that also take into account likely population movements and changes in population density that could occur, presumably as a result of climate change?
Not that I've seen. a bit like Jen. I'm not completely in my comfort zone talking about climate change, but I haven't seen any models that have actually taken into account increasing population density and changes in population movement and have used that to predict malaria distribution.
And one from me that's on a similar topic to that. The current versus 2080 malaria distribution predictions were really quite stark differences there. Was that purely based on temperature change, or were there any other climatic change effects?
It was basically just temperature in that case. And 2080 was the prediction was that initially it would actually increase because as temperature gets slightly hotter than it is now, then malaria actually increases globally. But then as they get much hotter after that, that's when it starts declining. And it was just temperature.
But following on that note, why only temperature? What about humidity?
So the models that the models that overlay climate data over malaria can include things like humidity. The models that use the transmission models, basically they're limited on what data they have on how all of those parameters change with various factors, and I think basically there's just a lot more data on how these things change with temperature than with humidity.
Good, Eric. There was a hand here. Yes, what do you?
Thank you. The two speakers spoken about the effect, the vectors on the population. Have you measured the impact on the behavior of people who are affected by these climate changes, while how they could adapt themselves toward the consequences of the climate change as well as the disease they face in their territories? Because I can see that more researchers are focused on big cities. What about the countryside? I can give an example. I'm from Congo. In my village, when I was young, the rivers were very, very deep. But after 30 years I left, today I hear that I can walk on the same rivers because of the climate change. But they don't know that it's the climate change that reduces the river banks. Is there any plan for these affected population back in the countryside?
Not that I'm aware of. I'm not aware of people having looked into that. And as you say, people are going to have to adapt to the changing climate. That's going to involve changes in water storage, I think, like quite substantial. Like as often as you get aridity, you have to start storing water. And then again, that will probably reduce the breeding sites for things like the native vectors, but for something like Anopheles stevensii, then you're effectively giving them lovely breeding sites. So again, similar with people potentially not sleeping under bed nets as much because it gets too hot. So yeah, you're absolutely right that the practices are going to change as a result of changing climate, and how that then affects the spread of malaria is something that I don't think has been modelled and that we definitely do need to look at. Yeah, fully agree.
One more online, Dave.
Okay, so we've actually got a few, but I think maybe we hold over a couple. But one of the questions is, the model predictions that you were presenting were focused, primarily seem to be focused on the tropics. What about the risk of species moving into more temperate climates, for example, settling in Europe, due to a rise in temperature and perhaps longer summer conditions?
Yeah, no, so that is a prediction of the models, that you do get slight increases in malaria in those areas as well, but they remain relatively modest compared to the levels of transmission that we're seeing in Africa and that we continue to see in Africa even under the climate models.
Thank you very much, Eric. We stop here for now. We come back during the panel discussion. Thank you, Eric. We now move to our last speaker, Rachel Tolhurst. She is from the Liverpool School of Tropical Medicine, and she'll be talking about health policy and system research, climate change, and urbanization. Rachel, over to you.
Morning, everyone, and thanks for having me today. I prepared this presentation together with my colleague Surekha Garimella at the George Institute in India. Unfortunately, she's not able to join today, so I am left making the whole presentation. Very sorry about that. She sends her apologies. And the presentation draws on the work of many colleagues, too many to name and acknowledge, from the ARISE Consortium and beyond, but I'd particularly like to acknowledge and thank the ARISE team at LSTM and ARISE partners in our partner countries, Sierra Leone, Kenya, India and Bangladesh. And some of you I know are here today and can help me answer questions. I'm also a little out of my comfort zone, as I think we all are when talking about climate change, but maybe that's the point, as Jen so brilliantly said. So it's probably not news to you that the planet is undergoing urbanisation at a massive scale, with 6 out of 10 of the global population predicted to live in cities by 2030, and 90% of this increase coming from low and middle income countries, particularly in Africa and Asia. And we've already seen how urbanisation itself accelerates climate change in many ways, as well as the health impacts of climate change. And urbanisation also brings particular health challenges, particularly, again, in the context of climate crisis and social and economic inequality. So building on the work of the ARISE Consortium, we're conducting research with urban marginalised people who really bear the brunt of the health challenges associated with climate change, particularly currently through the Urban Shade project, which looks at working together with urban marginalised people to improve the responsiveness of health services to extreme weather events. So today I'll be sharing some thoughts on the particular challenges and the research and action that's needed to address them. So first of all, very much following on from what Jen presented, I'd like to anchor these thoughts in the concept of climate injustice. That is, that people who are socially, politically and economically marginalised, both globally and within cities, who have contributed the least to carbon emissions, are bearing the brunt of the health challenges that they bring. And I could talk a lot about urban inequality, there's a lot to say, but I'm going to focus today on people living in urban informal settlements, which can also be popularly known as slums. And currently half the world's population live in cities, and a third of these live in urban informal settlements. And this rises to an estimated 56% of the urban population in sub-Saharan Africa. So through ARISE, we've worked with people living in urban informal settlements to understand their vulnerabilities and capacities and the hazards they face, as well as the range of environmental hazards that are created by the places that they have to live. So the top picture, there we go, shows the Cockle Bay informal settlement in Freetown, where mud and tin shacks are built on land that's manually reclaimed from the sea, so causing a lot of very frequent flooding, particularly during storm surges. The picture in the middle, getting used to this pointer, is also from Freetown, from the Dwarzak informal settlement, where you can see it's built on very hilly terrain, which is being deforested with increasing settlement and causing risks of landslides, and there have been catastrophic landslides in Freetown. The picture here is actually formal low-income housing in Ahmedabad, India, to which people were moved from informal settlements due to infrastructural development. But despite officially being formal housing, the very poor quality of the housing and the environment around it means that risks of heat and flooding remain high. Then we have a picture here from Vijayawada in Andhra Pradesh in India, where you can see the poor quality of the infrastructure and drainage leading to standing bodies of water. And we've heard about the many risks of mosquitoes breeding. And finally, we can see on the bottom left here the fragility of housing in urban informal settlements in Shimla in Himachal Pradesh. And these are all sites that we've worked in through Arise and are continuing to work in. So economic and social inequalities mean that vulnerabilities to hazards are not evenly distributed even within urban informal settlements, where housing typologies vary, as do incomes and the social networks and support that people need to recover from disasters. However, the majority of people living in urban informal settlements work for daily wages and have precarious incomes and livelihoods. Their work often involves working outside, for example, through waste picking or manual labour, which reduces their capacities to respond to prevent ill health, for example, by following heat guidance to rest during the hottest part of the day. So just to dig down a little bit further into the vulnerabilities of people living in urban informal settlements, the right-hand picture shows tin shacks, which are a very common form of housing in Sierra Leone, in the urban informal settlements, locally known as pan body. And you can see also the density of these shacks. So these intensify the urban heat island effect. So research in South Africa has shown that for people living in poorer settlements, the indoor heat temperature can be 4 to 5 degrees C hotter than the outside environment. So in addition to exacerbating diseases like hypertension and diabetes, dehydration is a major risk for the urban poor, who both struggle to access water and also pay higher unit costs for it. And we know that that may also reduce cognitive capacities. So if children's educational attainment is affected, for example, then that will further entrench urban inequalities. And mental health is also likely to be adversely affected, with rising rates of anxiety and depression, and as well as intimate partner violence, which particularly affects women. Floods and landslides may also destroy infrastructure. I wanted to say something more about heat and wind. So both increased heat and wind can create compound events, including risks of fire and increased risks of urban pollution. So people living in urban formal settlements are more vulnerable to the destruction of their homes and also potentially to fire through informal connections to electricity and cooking on open fires. So we've seen a little bit about flooding and landslides already, which can destroy housing and other infrastructure, as shown in Freetown in the left-hand photo, but may also disrupt sanitation and clean water supplies, leading to increases in diarrheal disease and reduced access to food, potentially due to damages to roads, and that's just one of the many potential impacts on the food system. So within informal settlements as well, people with disabilities and the elderly may struggle to rapidly evacuate their homes during storms, flooding or fires. And we've also seen how extreme weather events have acted as a trigger for eviction by city authorities. So, for example, in Mathare and Nairobi, there were severe floods this year and people were evicted without support for resettlement from the most vulnerable areas of the settlement next to the river. And those were also the most socially and economically marginalised people. So what about the effects on health services? So extreme weather events can exacerbate both provision and access to services by urban marginalised people who already face physical, financial and often social barriers to access. Public primary healthcare services are already too limited in provision for the populations who often have to use informal private clinics like the one on the left-hand side from Viwandani in Nairobi. And the health system is generally poorly prepared for addressing the health challenges of people and the changing needs during extreme weather events, including a lack of localised information on changing disease burdens. For example, there are rarely linkages between meteorological and health services that would enable planning for emergencies, including increased demands for services. Health infrastructure may be damaged by storms or flooding. So on the right-hand side, this picture shows the physical access to a community health centre in India being damaged by flash floods caused by heavy rainfall in Himachal Pradesh. And water and electricity supplies may also be affected, reducing possibilities to maintain existing services and quality. Buildings may also exacerbate extreme heat for both health service providers and users. So, for example, the middle picture shows a primary healthcare centre in India with iron doors and window coverings exposed to direct sunlight from all sides and with no internal cooling source, causing unbearably hot indoor temperatures even now. Frontline community and clinic health workers are likely to be directly affected by floods, for example, or fires, affecting their ability to provide services, and their emotional resilience is likely to be further decreased by extreme heat. Damage to already fragile roads and pathways within informal settlements will further reduce physical access to care, particularly for the elderly and disabled, and financial access is also likely to be decreased if livelihoods and food access are disrupted. So what kinds of research and action are required to support health and other service responses to these multiple challenges? Well, there's a lack of granular data at different levels to enable services to understand risk and how it's distributed. Risk is understood within the most recent Intergovernmental Panel on Climate Change. Sorry, just had to get that IPCC full detail out. So within their framework, as a function of exposure to hazards, vulnerabilities, sensitivities, and adaptive capacities. And assessing this requires data at different spatial levels. For example, while city level or regional meteorological data may forecast a heat wave, there's generally no data on how increased heat is distributed within cities or settlements. And we need both objective and subjective measures here, because there are studies that have shown that people's experience of heat may not match the recorded temperatures. And we also then need to layer socio-ecological data about economic and social vulnerabilities and capacities to enable targeting of responses. So what are some of the potential ways forward? So first, we've learned through the ARISE Consortium working with vulnerable people during the COVID pandemic, and this is really drawing or building again on what Jen was talking about, that collaboration needs to be rooted in solidarity. Researchers cannot withdraw in emergencies and need to be ready to support emergency relief efforts, such as the Centre for Relief for People Affected by the recent flooding in Andhra Pradesh on the left-hand side, provided by our grassroots partner. And really this raises the need for flexible funding. We were lucky enough in ARISE to have flexible funding to enable us to pivot and support people in emergencies. That's not always the case within research. Secondly, both communities and local systems actors need to be involved in assessing risk and planning and implementing responses. People living in urban informal communities are capable of and do collect and analyse and use their own data to make demands for improved services. So, for example, in the image on the right, we can see members of the Federation of the Urban Poor in Mathare, Nairobi, who collectively enumerated and mapped their settlement and used the data to create a physical addressing system which is being used to improve the targeting of community health worker services. And clearly further efforts are needed, but this could be used further to link people to multiple services, including disaster relief. And underpinning this really is community solidarity and aggregation to demand improved services from accountable actors such as the government, as well as improved infrastructure. So finally, capacity strengthening of health system and other departmental actors is clearly needed, along with attention to how to strengthen interdepartmental collaboration beyond the health sector, because clearly many of the factors influencing these urban health challenges are the property of many other sectors, and as Jen said, all of our responsibility. So in Urban Shade, we'll be taking forward these approaches with communities, healthcare managers and providers to co-design and evaluate interventions to improve the preparedness and responsiveness of health services. And we'll also be working on a new project funded by IDRC, led by my colleague Lana Whitaker, on supporting the development of community resilience centres, community access to climate financing, and context-specific approaches to improving housing, materials and design. And that's in collaboration also with the Roof Over Our Heads programme, which is an international programme led by Slum Dwellers International. Thank you.
Thank you very much, Rachel. We have time for questions. Yes. Over.